the mitral valve anatomy. If you are using trans-thoracic echo, you can still do a full analysis of the mitral valve anatomy in order to understand if the patient has mitral regurgitation, from where exactly this regurgitation is coming. This is by deciding what are the scallops that are leaking and what are the scallops that, even if they are prolapsing or tented, they are not leaking. This is very important. If you are sending this patient for edge-to-edge repair or for surgery, it is not accepted nowadays to just say mitral regurgitation without localizing from where the jet is coming. And I'm going to tell you now a step-by-step approach how to analyze the mitral valve scallops by the trans-thoracic approach, using only 2D and then using X-plane and then using three-dimensional trans-thoracic echocardiography. Let's see it together. Well, this patient has a dilated left ventricle, ischemic heart disease. That's why we have some wall motion abnormalities and tented and tethered mitral valve leaflets. That's why we expect that this patient may have functional mitral regurgitation. Now the question is, which scallops are leaking? In the long axis, in the parasternal long axis view, because we are cutting the aortic valve and the ascending aorta right in the middle, that means we are cutting also the middle of the mitral valve. So the middle of the mitral valve will be A2 and P2 scallops. If you are looking to the mitral valve in the short axis view, we are seeing all the scallops, the anterior leaflet and posterior leaflet. Anterior leaflets take the letter A, so A1 counting from lateral to medial, and then A2 right in the middle below the aortic valve, that should be here, and LVOT, and A3 near the septum. And the same for the posterior leaflet. P1, the most lateral one, P2 just beneath the LVOT right in the middle, and then P3. So the anterolateral commissure will be A1 and P1. The posteromedial commissure will be A3 and P3. In the parasternal long axis view, we are cutting like this. In the long axis, we are cutting the aorta, LVOT, ascending aorta, and then A2 and V2. That's why any long axis view, parasternal long axis, apical long axis, transesophageal, mid-esophageal long axis, we're usually saying A2 and P2. Good. Knowing this fact, if my probe is cutting in the parasternal long axis view and cutting like this, what will happen if you tilted your probe down to the patient? So down, you will get the RV inflow view that shows the tricuspid valve. Good. And the septum. Come back from the RV inflow, come back from the tricuspid, you will face the interventricular septum, and the first scallops you will see coming after the septum will be A3 and B3. In that case, the aortic valve and LVOT will not be fully open. And then you carry on to reach the standard parasternal long axis view, which will be A2 and B2. Carry on to the lateral, which is the RV outflow view, where you will see the pulmonic valve. As I will show you now, you will see one-on-one and then the pulmonic valve. So this is called long axis sweep. Let's do this. Good. I started here by the standard parasternal long axis view, and then I'm tilting now in to the tricuspid valve, and then coming back from the tricuspid, the first scallops will be 3 and 3, and then more to the left, standard parasternal long axis, and then one-on-one, and then after that, the pulmonic valve. See, this is called long axis sweep. Again, starting from the parasternal long axis, RV inflow. Now I see the tricuspid, interventricular septum, and then coming back to the mitral, the first scallops will be 3, 3, and then 2, 2. Here the leak is at 2, 2, and then 1, 1, just before the RV inflow where you see the pulmonic valve. I am sure you understood what I'm doing now. From the parasternal long axis, RV inflow, come back from the RV inflow, first scallops will be 3, 3, they are intact, no leak here, and then parasternal long axis, standard 1, 2 and 2, and then just before the pulmonic valve, we will see 1-on-1. This is called long axis sweep. I do this with color compare in order to assess the anatomy and the function at the same time. Somebody will tell me, why bother? You can get the short axis view and just apply color with color compare. Now I can see the jet coming exactly from A2, B2, no jet from 1-on-1, no jet from 3 and 3. You are absolutely right. However, because mitral valve orifice is curved like that. So this curve, you may only cut at the tips, which are A2, B2. Even if the commissures are leaking, you may not see that at the level of the tips cut. And if you went back a little bit, you will see leak from the commissures. So the short axis in the mitral valve may not be so conclusive because the mitral coaptation is curved like that. If you cut at the tips, you may miss the commissures. What if you have three-dimensional probe? Now you can start by the short axis view, because as we said, short axis shows you all the scallops, and then you apply X-plane. X-plane is a biplane mode, of course, but you will not be able to do an X-plane unless your probe is 3D capable, because X-plane comes out of the three-dimensional volume. Here, I'm looking at the mitral valve on-FASE view, the short axis, and then I dropped my X-plane line right in the middle. That's why I see here a long axis view. So A2 and P2. Now I am putting my cursor line at the medial commissure A3, B3. So A3 and B3. Now the lateral commissure 1 on 1. So here A1 and P1. Now I'm doing this with color. The lateral commissure 1 on 1. No leak. The medial commissure 3-3, no leak, no regurgitation. And now I'm right in the middle of A2 and B2. Here I could find the mitral regurgitation. So this is another way of scanning the whole valve from one side to the other side using the X-plane. And then, of course, if you have three-dimensional trans-thoracic echo probe, you can look at the mitral valve on-FASE view from the LV side, like what I'm doing here. I'm saying LV side because I see the chordae and subvalvular apparatus. But if you do 3D rotate and rotate like that, now I'm looking like doing surgical view of the mitral valve, aortic valve 12 o'clock position, anterior leaflet, posterior leaflet. Here is the septum, and here is the appendage. So lateral, 1 on 1, 2, 2, and 3 and 3. And then you can apply color, and then you see from where the jet's coming. Here is much better than the 2D because you will be able to see the commissures at the same time. And that was a quick overview of how to analyze the mitral valve anatomy using 2D only, and then X-plane, and then three-dimensional trans-thoracic echocardiography. And thank you.